everyone. Today we have Dr. Lionel from ID here with us to discuss about bacteremia, specifically gram-positive cocci bacteremia. Thank you, Dr. Lionel, for having with us this session.
Yeah, thanks for having me.
So firstly, we'll go through a case scenario. It's Mr. John, who is a 21-year-old Chinese gentleman who presented to the ED with a fever of 1 day duration. He also had right-sided lower back pain of about 3 to 4 days duration and an aching sensation down his right hamstring. He did not have any other neurological symptoms otherwise, and there was no trauma or injury to his back. So on physical examination, he's non-toxic looking, he's febrile, 38.4 degrees, but is otherwise hemodynamically stable. He does not report any spinal tenderness on percussion, but his right hip flexion is limited by pain. So on his initial blood works, he has a neutrophilia, HB is normal, and the other labs are quite unremarkable. The CK is mildly raised 130, and the CRP is also raised at 187. The blood cultures were also sent off. And after 5 hours into his admission, it turned positive for gram-positive cocci in clusters. So the question we wanted to discuss was what is the significance of gram-positive cocci infections, as it is quite common for on-call to receive this notification as well. So we just wanted to discuss how we should respond to this.
Okay. So if you could go to the next slide. So in general, when we get a call from the lab regarding blood culture positivity, and it reflects out as gram-positive cocci, then you start thinking whether it's in chains or in clusters. If it's in chains, then you start thinking whether it's a streptococcus or enterococcus. And by and large, if you look at streptococcus, there's a wide range of streptococcus. There's group A strep, which is also called strep pyogenes, usually causing skin and soft tissue kind of infections. Group B strep, called strep A galactia, and then you have strep pneumonia, which is commonly known to cause pneumonia as well as meningitis and sinopulmonary infections. Strep viridans, usually originating from the mouth, the gut, and then of course strep bovis. We'll talk about it later. Enterococcus itself, there are two common ones, Enterococcus faecalis and Enterococcus faecium. In general, they come from the gut, sometimes the urinary system, and occasionally, if it's persistent, we've got to think of infective endocarditis. For gram-positive cocci in clusters, once they flag out as in clusters, then we start thinking whether this is MSSA or MRSA, or it could be coagulase negative staph. I think for MSSA and MRSA, we probably will go through a bit later on. But for coag negative staph, there can be many species. Staph epidermidis is one. I just wanted to point out that Staph lugdunensis is one of the coagulase negative staph that it's rather pathogenic. It behaves more like Staph aureus itself and can cause bacteremias with osteomyelitis and skin and soft tissue infections. So not all coagulase negative staph can be treated like contaminants. Particularly Staph lugdunensis can cause all these metastatic complications. The other thing about coagulase negative staph that we're talking about in terms of contaminants is that if it doesn't clear, if the coag negative staph bacteremia doesn't clear and there's a presence of a prosthesis, so for example, there is a line, a PICC line, then that cannot be treated like a contaminant. It has to be treated as a real pathogen causing like sepsis. Okay, so this is an overview of gram-positive cocci in chains and clusters.
I see. Thank you, Dr. Lionel. That was very helpful in looking at the overview of the different types of organisms that this microbe alert could be.
We touched on the clinical significance of gram-positive microbiology, but we should also talk about what the empirical antibiotics are when you see a GPC in chains on call. So usually ask yourself where you think the infection is from. If it's cellulitis, right? Then you see GPC in chains, it's most likely going to be strep. So I would start penicillin. If you see that the patient has a bit of gut, may have a gut sores, diarrhea and all those, then Enterococcus is also one of your considerations. Some people may add on vancomycin. By and large, in those people with intra-abdominal sepsis, they are on already ceftriaxone and metronidazole. So the ceftriaxone would usually cover the strep. But for Enterococcus, the cephalosporins do not cover Enterococcus. So you may need to give vanc, or if you use augmentin, then that's fine. Augmentin would cover the strep as well as Enterococcus faecalis. For GPC in clusters, then of course, you really want to ask yourself whether could this be contaminant or not. Sometimes it's hard to tell, particularly in those with lines and PICC lines and things like that. So one way is really to give vancomycin. That would target MRSA, that would target MSSA, although not ideal, and that would target also coagulase negative staph. Until your species are out, then you tailor your antibiotics. I did want to mention how do we differentiate contaminants and pathogens just by looking at the number of positive blood cultures. So if you have someone with just one positive blood culture and it's coag negative staph, you might choose to ignore that and treat it as contaminant in the absence of prosthesis, because if it grows slowly or it's just one bottle being coagulase negative staph, that may be a contaminant in the context of someone who you repeat the blood cultures and the coag negative staph does not return again. But if the patient does have prosthesis and you see GPC in clusters, I'm not too sure whether we can say that's a contaminant as yet, because coagulase negative staph can cause prostatic infections, prostatic heart valves, or even prostatic joint infections as well. Other culture sites, so we are talking about strep and staph or gram-positive cocci in urine cultures. I would say for strep in urine cultures, the most common we do see is in pregnant ladies, obstetric follow-ups with group B strep in the urine cultures. Okay, so those can cause urinary tract infection. Staph saprophyticus is a coagulase negative staph that can cause urinary tract infections in young sexually active females. Enterococcus can cause urinary tract infections, particularly in the elderly. In men, it can cause prostatitis as well. Then the last thing I want to emphasize is Staphylococcus aureus in urine cultures. So that's has come up a couple of times, and questions have been asked about that. And I must say that when you see Staph aureus in urine cultures, please do a blood culture, a corresponding blood culture, because it could signify a bacteremia. Okay, and sometimes staph in the urine cultures may also be real, because it could be a staph prostatitis, staph renal abscess. So that a staph in the urine cultures are not to be taken lightly. You have to make sure that the patient is not bacteremic and not have a urinary tract infection. For respiratory cultures, you do see gram smears showing gram-positive cocci in chains quite frequently, and that's because strep viridans and a lot of the strep occurs in the oral mucosa. However, the one that I would be very careful about is strep pneumonia in respiratory cultures. So that's really significant, because obviously strep pneumonia can cause severe pneumonia in our patients, particularly in those with splenectomies and complement deficiencies. Staphylococcus aureus can also cause necrotizing pneumonia, and that's usually in the context of someone who has post-viral infections, post-respiratory viral infections. So we do see time and again when a patient with flu, influenza, or RSV, or even COVID, having a secondary bacterial pneumonia, and that's usually from Staphylococcus aureus or Streptococcus pneumonia.
Can I ask how we should interpret the respiratory cultures? Because I understand that you have to pair it together with the Gram smear to see if it's significant.
Yeah, so in general, if the Gram smear has multiple gram-positive cocci, gram-negative, and multiple organisms there, then we tend not to treat it too seriously. Although I must say that ultimately you would have to look at the patient clinically, and if there's increased sputum production, increased oxygen requirements, and the chest X-ray does show that there's a pneumonia, you would have to treat the sputum cultures seriously. Yeah.
Moving on with the case scenario, the blood cultures eventually grew Staphylococcus aureus. So in view of the persistent back pain, MRI spine was performed, and which eventually showed that there was L4 to L5 facet joint septic arthritis, as well as collections extending into the right posterior paraspinal tissues and the spinal canal.
Yeah.
So this brings us to our next point of discussion, which is regarding the evaluation of Staph aureus bacteremia. As we are wondering, what are the usual common sources of infection, and what investigations should be part of our evaluation workup for Staph aureus, and whether there is any role for TTE or even TEE, as well as clearance cultures.
All right. So the next slide, please. So the common sources for Staph aureus would be skin and soft tissue. But I would say that it's sometimes quite difficult to pinpoint the source or the site of seeding for Staph aureus. And as you know, Staph aureus will never be treated as contaminant. The mortality is usually about 20-25% at 3 months. It's quite a sticky organism. It does stick onto prostheses. So besides looking at your skin and soft tissues, you also want to make sure that the patient does not have a prosthesis inside too. For example, prosthetic valves, pacemaker leads, dialysis lines are quite common source of infections, PICC lines, even your arteriovenous grafts and stents, right? So prostheses and skin and soft tissue are probably the sources, the most common sources of Staph aureus. Most of the time, we do get patients telling us very obvious sources. For example, eczema, they had gone through acupuncture, they had a knee tap or knee aspiration, they had some trauma, some cellulitis, or some muscle pain, pyomyositis. So majority of them would be able to tell you how they got it, but we do get also a significant number of patients who don't have very obvious sources of infection. The seeding sites can be many, and staph can affect almost any part of your body, including the joints, the spine. So sometimes they do get epidural abscesses, vertebral osteomyelitis, bones, psoas especially, as if you examine the hips and there's painful range of motions. Sometimes we do look at the psoas carefully. Any visceral abscesses is possible. We've seen people with kidney abscesses, prostatic abscesses, splenic infarcts, and even brain abscesses. And then, of course, the most important thing is really to look out for endovascular seeding in our valves and even in the aorta, where sometimes they can cause mycotic aneurysms. Okay, so that's about the source and seeding. The next slide would tell you a little bit about the investigations that you would do for Staph aureus. It's really largely guided by the symptoms the patient has. So, for example, if the patient complains of back pain, then obviously you want to image the spine. Or if there's joint pains, and you see a joint swelling and tenderness, then obviously you want to suspect septic arthritis. You may need to go for a joint tap, joint washout. Infective endocarditis is the other place that you want to look for points of seeding, especially when there's persistent bacteremia. So up to about 15 to 20% of Staph aureus patients have endocarditis, right? And usually we would, by standard of care, order an echo about 5 to 7 days after the onset of the bacteremia, really to look for valvular lesions. So TTE is pretty common. We do most of the time ask for TTE. But when do we go for a TOE or TOE? And the reluctance to go for a TOE really is driven by the nature of the procedure. It's invasive, it's added cost, and of course logistics needed to arrange for a TOE. If you just click the next slide. Yeah, so when would you consider a TOE? Mainly in patients who have persistent bacteremia or fever, someone whom you think maybe the patient has a paravalvular abscess that may not have been caught on the TTE. If you had an initial negative TTE, but you have a high index of suspicion for infective endocarditis, for example, if the patient has embolic phenomenon, vascular events, or stigmata of infective endocarditis, in the context of someone with a negative TTE, then you would proceed on to a TOE. If there is someone who had a Staph aureus bacteremia with no clear source and comes from the community, and has maybe pre-existing valvular lesions, has a previous IE or is IVDU, then in those cases, your antennas are already up for endocarditis. And in those cases, if you have a negative TTE, I would probably go for a TOE. And then lastly, if there's a prosthesis, so for example, prosthetic heart valve replacement in the presence of Staph aureus, you probably need a TOE as well. Okay, so the next slide.
Sorry, Dr. Lionel.
Yes.
Can I just clarify at this point in time? So, regarding the echo, so does that mean
Yeah.
that if we do it too early, like maybe say 2 to 3 days after the first blood culture, it may not be actually
That's right.
reassuring if
That's
it's
right.
negative?
So it really depends on how soon you do the echo. I tend to wait a little bit longer because you need time for seeding to occur. So generally we say about 5 days is fine. 3 to 4 days it's fine, but don't do it too early on the first day of bacteremia. Really, it depends on the duration of bacteremia as well, and duration of symptoms in the patient as well. The fever has been going on for a week, then okay, that's fine if you order the echo early. But if it's just 1 or 2 days of fever, then I might wait a little bit longer before I order echo.
I see. Thank you.
Yeah. The other question about clearance cultures is that we do routinely ask for repeated cultures to document clearance of the bacteremia, and usually about 24 to 48 hours post starting treatment. If it is negative, good for the patient, but if it's positive, we will keep repeating it until it clears while trying to achieve source control. The number one reason for persistent bacteremia is really inadequate source control. And usually what we define as persistent bacteremia, in the past, it used to be 1 week, then it reduced to about 48 to 72 hours. So the goalpost keeps changing. But anyhow, I think if there's someone who doesn't clear the bacteremia despite appropriate treatment and adequate source control after 48 to 72 hours of that, then that's considered persistent bacteremia. And we all know that with persistent bacteremia, the mortality rate actually increases. What does it mean when you have persistent bacteremia? It means that the patient does have a high bacterial burden. So meaning you either haven't achieved source control or you haven't addressed the source control, or the patient has a very high burden like endovascular infection. And the implications of having persistent bacteremia would mean that this is by default complicated bacteremia, Staph bacteremia, and that would mean that the patient would get a longer duration of treatment, typically 4 weeks or more. Yeah. The next slide.
Does this also mean that because I think previously you were discussing about the indications for a TEE. So
Mm,
if the patient has persistent bacteremia, even though there's no like murmur or existing valvular lesion, will this also prompt us to do a TEE
that's
instead?
right. That's right.
Okay.
Yeah.
Moving on
Okay.
was with the management of the Staph
Yeah.
aureus
Okay.
bacteremia. So
Yeah.
I understand that I think that there is some evidence somewhere that says that actually ID should be on board, and it
Yeah.
apparently improves mortality rates for patients with Staph aureus bacteremia.
Mhm.
So we are wondering when one would be required, and also what is the antibiotics of choice for both MSSA and MRSA bacteremia, and if augmentin is effective if we require a broader spectrum coverage, like if there's another
Yeah.
source that we need to cover for, and regarding the duration of antibiotics.
Okay. If you go to advance to the next slide. So there are reviews and there are many papers looking at the role of ID in treatment of Staph aureus. A lot of them are retrospective, but it does show quite significantly that when ID physicians on board, the 90-day mortality drops and relapse rate drops, and there's lower readmission rates. That's probably because we are quite particular about looking for metastatic complications. And also, in terms of treatment, we are a little bit more aggressive in pushing for source control, and also the dosing and the type of staph treatment, the antibiotic choice and dosing, that will also affect the mortality. So with ID on board, I think looking at source control, the dosage, and as well as the type of antimicrobials used, mortality rate does go down as well. Okay, so the next slide, the treatment of choice for MSSA first, maybe, is usually IV cloxacillin. We do have IV flucloxacillin, but it is used in the OPAD setting. So in the inpatient setting, we use IV cloxacillin. That's really the gold standard since the decades ago, but I must talk about the dosing for cloxacillin. If we are dealing with endovascular infections, then cloxacillin dosing should be higher, about 2 grams 4-hourly. Unfortunately, if we look at adverse effects, right, cloxacillin, if given a long time, sometimes can cause phlebitis and interstitial nephritis. So that's something that we often see in OPAD as well. The other thing I want to mention about cloxacillin and flucloxacillin is that you don't need to renal adjust the dose for cloxacillin, but for flucloxacillin, you do need to renal adjust the dose. The other alternative, apart from cloxacillin or fluclox, is cefazolin. In the past, there used to be concerns about cefazolin being inferior, but that theory has been debunked. Why was it considered inferior? Because theoretically, there have been reports of cefazolin having inoculum effect, meaning that it's in a high bacterial load, the MIC of the Staph aureus increases with exposure to cefazolin. But that's really not clinically proven to be inferior to cloxacillin. So a lot of times we do use cefazolin as well. It is very well tolerated, does have less adverse events compared to MSSA, particularly interstitial nephritis. The only thing I have to say about cefazolin is it does not penetrate the CNS. So if you're dealing with staph brain abscesses, then obviously no cefazolin, it has to be cloxacillin. Cefazolin has to be renal adjusted, but the good thing is that the dosing is 8-hourly dosing, whereas clox is going to be 4-hourly to 6-hourly, so a much more practical dosing. And in a hemodialysis patients, you can give cefazolin post-dialysis 3 times a week, and that would really be much of a convenience for your renal dialysis patients. In the olden times, sometimes we do give gentamicin together with cloxacillin, but that has really been shown to be really not good for the patient because there has been increased reports of nephrotoxicity with gentamicin. The reason for synergy is that it enables the clearance of the blood cultures to be faster, right? So some of them would give gentamicin on top of cloxacillin, but that's not routinely done nowadays. Rifampicin as a synergistic agent is seldom used nowadays unless there is prosthetic heart valve endocarditis, or there's orthopedic implants. Those are cases where we might consider adding on rifampicin, but by and large, we do not add on Genta and rifampicin routinely for routine bacteremia. The question about augmentin or even piptazo for treatment of MSSA, it's not ideal, but if you've got to treat, for example, say hospital-acquired pneumonia and you escalate to piptazo for about 5 days, that is fine. But after you treat the 5 days of piptazo for the hospital-acquired pneumonia, you should go back down to cefazolin or cloxacillin to complete the course for Staph aureus. Then, of course, we are talking about vancomycin being inferior for MSSA bacteremia because we have seen reports of cases being treated with vancomycin with increased relapse rates and persistence of bacteremia. The treatment of MRSA, on the other hand, is vancomycin for now. And I just need to emphasize that we need to achieve therapeutic levels quickly, and hence I would usually load the patient on start 25 to 30 mg per kg, and then thereafter 15 to 20 mg per kg 12 hourly. That's for someone with good renal function. And then, of course, to your therapeutic monitoring, routinely we do say keep the levels about 15 to 20, but that's on the assumption that the MIC of the MRSA to vancomycin is 1 or less. As you can see, AUC over MIC is the pharmacodynamic target that we are targeting. So AUC over MIC must be more than 400. So assuming that the MIC is 1 or below, then the levels that usually we target is 15 to 20, but that's very, very arbitrary and ballpark. So nowadays, you do see sometimes that the pharmacist asking for more levels to be taken, and they use a calculator to compute the AUC over MIC to see if they reach that pharmacodynamic targets, and they adjust the dosing accordingly. The duration of treatment for uncomplicated staph bacteremia, it's usually 2 weeks from the last negative cultures, whereas we did mention earlier that if it is complicated bacteremia, then the duration would be at least 4 weeks, sometimes longer. And what we define as complicated bacteremia is someone with persistent bacteremia, someone with metastatic complications, endovascular infection, someone with a prosthesis or lack of source control. Yeah. Next slide.
Can I ask for this at least 4 weeks of antibiotics? How would you decide, like after 4 weeks, whether you extend it to 6 weeks or 8 weeks?
Yeah. So usually in someone with vertebral osteomyelitis, say, for example, usually it's 6 weeks. For someone with endocarditis, we usually stretch up to 6 weeks in those, say, for example, with paravalvular abscess or prosthetic heart valves. But generally, we go by the clinical response, the CRP, and the degree of source control. Say, for example, if there's epidural abscess and you image and there's still a residual collection abscess and the CRP is still not flat, then sometimes we do stretch a bit longer, although it may not necessarily be IV vancomycin for the whole time. Sometimes we do oralize them to a susceptible antimicrobial, so for example, Bactrim or minocycline. Okay.
I see. Thank you.
Talking about oral antibiotics for Staph aureus, in the past, we used to always say that for Staph aureus, it needs to be IV all the way. But increasingly, we are seeing reports of use of oral antibiotics for Staph aureus after an initial IV course that can be successful, but only in a select population. And that's good because it does decrease our length of stay and the needs for lines and cost and the problem is that this needs the patient to be very compliant with oral antibiotics. I would suggest not for teams to transit to oral antibiotics without discussion with IDE, because we really are looking at a very specific subgroup of patients that can do this. And there are trials going on nowadays to evaluate whether this would be feasible or not. But by and large, in the 1990s, we do have, say, for example, IVDUs with right-sided infective endocarditis being treated with a combination of oral ciprofloxacin and rifampicin. And that showed to be quite equivalent to an IV course. Okay, so that's very, very early on data that possibly oral antibiotics may be able to be used for staph bacteremia. And then recently, or rather a couple of years ago, there was a trial called POIOT. POIOT is a trial done for endocarditis patients, and they were looking at giving patients an IV course for 10 days, then after that oralizing to the patient to a combination therapy. In that trial, I think majority was strep, but about 20% was staph, and they used a combination of diclox plus fusidic acid or diclox and rifampicin. So there is increasingly more evidence that in subgroup of patients with good source control, that we may be able to use oral antibiotics. So I just want your antennas up for the Sabato trial. The Sabato trial is still recruiting patients, if I'm not wrong. It's looking at the role for early oral switch after initial IV course. But for Staph aureus, we are looking at a very, very specific group of patients where the Staph aureus is acquired in a healthcare setting, meaning maybe it's a plaque site phlebitis or something like that. No prosthesis in situ, no IE, no metastatic complications. The patient had cleared the cultures after 72 hours, and the patient is stable. Those patients were recruited for early oral switch, and we eagerly await results from that.
Okay, I think moving on, we'll move on to Streptococcus species with regards to what are the common sites of infection, as well as what's the workup usually for the source of infection.
Okay, yeah. So I decided that there are too many Streptococcus around. So I put the most commonly encountered ones on this slide. Generally, group A strep or strep pyogenes. It can cause necrotizing or skin and soft tissue infections. And we do know that it's one of the organisms for neck rash as well. It can also cause bone and joint infections, throat infections. For group B strep is called strep agalactiae. It does come from a variety of places: skin, gastrointestinal, genital, urinary, even bone and joint. There was an outbreak, I think 2014 or 15, where there has been cases of invasive group B strep bacteremia causing metastatic complications, even to the CNS. The bone and joints caused by this strain 283, and it was related to eating raw freshwater fish. Then, of course, we have strep dysgalactiae, largely skin and soft tissue, bone and joint infections. Strep pneumoniae, you're all familiar with sinopulmonary infections, meningeal infections, rarely bone and joint and endocarditis. Strep viridans is from the gut, but the worry is whether it can cause IE in some people with predisposing valvular lesions. And then occasionally we do see strep galolyticus, or what we call strep bovis in the past. It comes from gastrointestinal tract and can cause infective endocarditis. Usually with this strain, we would recommend colonoscopy just to rule out the colorectal malignancy. So you can see that not all Streptococcus behave the same way in their propensity for endocarditis, right? So if you look at maybe focus on the green part. Low-risk streptococcus, you have strep pneumonia, strep pyogenes. Generally, those don't really cause IE. The risk of IE or prevalence is really less than 3%, unless you have patients who have multiple positive blood culture results yielding that same strep, and the patient does have some risk factors, native valve disease, previous endocarditis, prostatic valve or cardiac device. Okay, then in those cases, we would pursue the diagnosis of possible endocarditis. There are some streps that are moderate risk, strep A galactia, your group B strep, strep anginosus, strep dysgalactia, and so on. Those there is a chance that it could be endocarditis, but only in the context of, again, persistent bacteremia or very high-grade bacteremia, and in the presence of risk factors that we have mentioned earlier, native valve disease, previous endocarditis, prostatic valve, or cardiac device. And in those cases, we probably would pursue a TTE, and plus minus a TOE if it's high-grade bacteremia. And then very high-risk streptococcus that I usually would move on towards an echo is strep mitis, strep auralis, strep parasanguinus. The G adiacens is granulocytella. It is a nutritionally variant strep that comes from the oral cavity. It does have high risk of endocarditis, so in those cases, we probably will move on to a TTE. And then, of course, the high-risk streptococcus, like very high-risk streptococcus, like strep galolyticus, mutans sanguinis, we go straight for TTE, regardless of the number of blood culture positivity.
Yeah, thank you for going through all those different streptococci. Can we also ask how do we approach the choice and duration of antibiotics in this species then?
Yeah, so it's very clinically driven. You look at where the source of infection is, or where are the sites of infection. So, for example, if you have strep pneumonia, meningitis, the duration is going to be different from strep pneumonia endocarditis, right? So similarly, if you have strep viridans bacteremia from maybe a dental procedure, it's going to be different from a strep viridans bacteremia from with endocarditis. So with endocarditis, it tends to be longer, 4 weeks at least. For usual uncomplicated strep bacteremia, anywhere 7-10 days is fine. The treatment for strep is usually our good old penicillin. Penicillin or even ceftriaxone is second line, but if it's sensitive to penicillin, I would suggest penicillin. The choice of treatment, whether it's penicillin or ceftriaxone, also depends on whether the strep is sensitive to the penicillin. And we look very closely at the minimum inhibitory concentration when we are looking particularly at sites where you need good antimicrobial penetration. So for example, strep pneumonia meningitis, we are looking at rather low levels of penicillin MIC of 0.06. If it's more than 0.06, sometimes we actually move the patient to ceftriaxone for strep pneumonia meningitis. For strep viridans IE, if the MIC is more than 0.12, then we do add gentamicin on board on top of the penicillin. So there's lots of nuances in treatment of streps, depending on the MIC, the site of involvement, that would really change our antimicrobial choice and also the duration of antibiotics.
For the penicillins, would you recommend IV or oral to begin with, and will you oralize if depending on the patient's condition?
Yeah. So I think we usually start with IVs for a strep bacteremia. When the patients achieve source control, has clinically improved, CRP is coming down, fever has lies, we could consider converting to orals. That's not a problem. In the context of someone who has good compliance and does not have site of infection that needs adequate penetration using IVs. So for example, for meningitis, I probably wouldn't use oral, but if it's just a bacteremia from maybe a dental infection, then I could possibly use oral. Okay, so it really depends on the site of infection and what you are treating and the clinical progress of the patient.
I see. And what if the patient is allergic to penicillins, inhibiting the use?
Yeah, so there is cross-reactivity with penicillin depending on what kind of allergic reaction. So if it's a mild rash, usually I would challenge a cephalosporin. And a lot of times you realize that penicillin allergies aren't really real. So you've got to ask a little bit more about what kind of allergy. If it's a very mild rash or dubious allergy, then sometimes we can even challenge penicillin in the presence of close watch. But I would say that the cross-reactivity with penicillin and cephalosporin is less than 2% or less than 1% even. So sometimes we do challenge cephalosporins. I wouldn't suggest using penicillin when you are really allergic to penicillin, especially when someone has a severe allergy to penicillin, like a type 1 reaction or anaphylaxis. Then in those cases, I probably wouldn't challenge cephalosporins or any beta-lactam class. I might move on, unfortunately, to alternative classes like vancomycin. So those are the things that you really want to think about when you see someone labeled as a penicillin allergy. How severe is the allergy? Do you think you can challenge with a beta-lactam of a different class? So those are the considerations you need to take on. Yeah.
Okay, thank you. I was wondering if there was any whether there's any summary or take-home points that you'd like the audience to take back with them.
Yeah, I think firstly, Staph aureus is never a contaminant, and you should never treat Staph aureus lightly. That's the first thing. The second thing about Staph aureus is to decide for yourself whether this is complicated or not, because those have implications on treatment duration and also how you manage the patient, because the most common cause for persistent Staph aureus bacteremia is really lack of source control. For strep, I think the main takeaway is that it's really dependent on the type of strep that you're dealing with and the source of infection that would determine the type of antibiotic and the duration of antibiotic. So there's no one size fits all. If you ask me whether there's a fixed duration of give IV, then oral, no, there isn't a fixed duration. It really goes by how the trajectory of the patient's clinical course as well.
Thank you, Dr. Lionel. I think that was a very useful session. I think I understand bacteremias much more now. Thank you.
Thank you.